What error?
We do not have an access to this page.
Should I send it again?
Yes, sir, please, because this is not downloading. There's some error coming.
It's sent again, but
It's not opening, so I'll just forward it to Mritika and ask.
Harika, can you try? I have sent it also.
Yes, I'm just trying to download.
Yeah. Sunilji, are we live?
Yes, sir, we are.
It is downloading, so just a moment.
Okay.
We already have attendees and.
Okay, then I'll start introducing Dr. Sangwan, and meanwhile, Harika, you can try. Good evening. We are slightly late today because of a technical issue with Dr. Sangwan's slides. We'll be starting the webinar very soon. Meanwhile, I'll take the opportunity to introduce Dr. Virender Sangwan, who is a excellent combination of being a great clinician, surgeon, and a researcher innovator. So he has all the four hats which he wears very comfortably. He and me started our careers almost together at LVPI. Virender, following his Corneal fellowship at LV Prasad, went to Orbis. He was the staff ophthalmologist there, and finally he was the director of Orbis Flying Hospital. And then followed by that, he did a uveitis immunology fellowship with Dr. Stephen Foster at Harvard, Mass Eye and ER. So he's possibly the only Harvard professor in Indian ophthalmology, right, Virender?
Yes.
Yeah. Then he had an illustrious career at LVP spanning over 2 decades. And currently he is returned to his home. That is, he was very fond of Haryana and the North. So finally he could come back after all his commitments were over in Hyderabad. And he's started his second innings, which is a great innings at Shroff Charitable Eye Hospital in Delhi. So Virender straddles between cornea and immunology. So he's possibly the best speaker we can have to talk on immunological overlays in corneal diseases. So over to him. But before that, we are uploading the slides. So that may take a couple of minutes. Meanwhile, Virender can give you some tips in life. He is a very good speaker, otherwise also fitness, lifestyle. Virender, over to you.
Yes. Thank you very much, Santosh, for the kind introduction. And yes, we go a long way back at LVP. Now, what I'm doing here at Shroff's Charity is trying to build a research ecosystem. At the same time, I disrupted myself in a sense that I was very established and having a very good system of research, treatment, and innovation. But I felt that, when you were well settled, that's the time that you should disrupt. And that's why I chose to decided to come back to Haryana. So I live in Gurgaon and work in Sarof Charity Eye Hospital. What tips for the young ophthalmologist I can give? Well, when we are young, we are trying to build our surgical career, clinical career. What we do is we depend a lot of on theory, on books, what we have read, and justifiably so. But what has helped me over the years is make your clinical observation. Start believing your eyes and trust yourself. Try what and the symptoms are. Do they reporting and your findings are matching or not? All right, let me switch to maybe my. Is this better now?
Yeah, voice is slightly better. Harika, you're ready with the slides?
Yes, sir. There is some problem with the sharing.
Just give us 30 seconds. Just give it 30 seconds.
All right. In the meantime, if there is any question or any specific question, they can post in the chat box. And Santosh or Harika, if you can.
Yeah.
I was saying that once you become an eye doctor, you tend to focus only on the eye and not the person. So what we need to keep in mind from very beginning of our career is that eyes are attached to a human being, and systemic disease are very important window. Eye is an important window for the systemic diseases.
We are on, sir.
All right. Can I move? Do I have the rights to move, or you will do it from there?
Harika, just put it on play. Then options may Virender, request for remote control. Virender?
Okay. Haji, from where I do that?
From your screen, laptop screen. You're seeing your slides, no?
Yes, I'm seeing the slides.
On the top, you are viewing Harika Regani's screen is in green.
Yes.
To that,
yes.
there is something called a view options.
There, but in that request remote control, yes.
Yeah. Just press on that.
Yes, request control to Harika's screen. Yes, request sent.
Harika, just approve.
Yes, I approved it.
Okay, now you can control Virender.
Wow, technology is very good. Now, still I'm not able to do Harika. It's
yeah, it's gone. No, next slide is come. There might be a second delay because it is internet speed that matters. No?
No, but it's not moving. I think Harika, you only do it. I'll keep saying next.
Okay.
Sure, sir.
Is that possible?
Yeah, very much.
So please go to the next slide. Yes. So here I'd like to present a case of a 32-year-old male, a software professional working in Hyderabad, who presented to us in 2013 in the emergency clinic. He had acute red eye of 5 days duration, discharge, stickiness, phone body sensation. Next slide. You can make out also there are ulcers in the oral mucosa. They were essentially dispersed not only on the lip, on the buccal mucosa as well. So there were various diagnoses in the emergency clinic which were considered like acute conjunctivitis, maybe bacterial, adenoviral. So he was given routine treatment and sent off. Next slide. He also gave a history of fever 1 week back, was treated with beta-lactam antibiotics, and then he had undergone a biopsy to rule out pemphigus and pemphigoid. Next slide. Over a period of time, his condition improved with the topical treatment, but essentially you can see there is a conjunctival chemosis, congestion, and there were bulbar ulceration in both the eyes, and vision was reduced in both eyes, and there were diffuse SPKs with thick conjunctival discharge. Next slide. So when we saw in the corneal clinic, we started thinking it could be a edema multiforme minor or a Stevens-Johnson syndrome. And we put him on intense lubrication and topical steroids. Next slide. After multiple visits and various diagnostic treatment and topical and systemic treatment, he started developing some dryness and tropion of the upper medial and tropion in the right eye. And his vision has improved in the both eyes, more so in the right than the left eye. And there is a relative dryness. There is a left eye Selmer's values are less than 1 millimeter, and in the right eye is 10 millimeter. Next slide. After 3.5 months, you see the eye look much better, but the entropion persists, the diffuse SPKs. And if you see the Purkinje images, if you pay attention on the Purkinje images of the cornea, the left eye cornea, the images are very dull. The dryness, you don't see any lacrimal lake along the lower lid margin. And in fact, in both eyes, but the right eye is slightly better because Purkinje images are slightly sharper as compared to the left eye. So we're dealing with a diffuse sort of dryness, ocular surface disease, and more likely than not, we were thinking that it's a Stevens-Johnson syndrome sequelae. Next slide. At this stage, we are also started questioning whether we are dealing with an SJS, acute SJS, or a mucous membrane pemphigoid with ocular involvement. Next slide. At this stage, we started treating him with systemic and topical steroids and immunosuppressives. He received intravenous cyclophosphamide, and then we had tried Prose lens, which is a kind of a large scleral lens. And by then we had done a conjunctival biopsy, and direct immunofluorescence showed a typical ocular cicatricial pemphigoid. On systemic treatment and topical treatment, he did continue to have conjunctival, episodic conjunctival inflammation, but was much better and he could function normally. So this OCP is a subset of mucous membrane pemphigoid, which is autoimmune, and it is characterized by subepithelial blistering and scarring. It is a potentially blinding condition because most of the time the diagnosis is not picked up, and it is usually delayed. Have ocular involvement, and it may involve the mucous membrane of the esophagus, skin, and other mucous membranes. Next slide. The differential diagnosis of this condition sometimes is quite difficult, but if you pay attention the kind of scarring and then you do a direct immunofluorescence, the diagnosis becomes clear in about 70 to 80%. Nowadays, we depend more on clinical clinical diagnosis rather than immunofluorescence. Next slide. So this is the whole list of differential diagnoses which you consider in chronic cicatricial conjunctivitis. It may be linear IA disease, bullous pemphigoid, lichen planus, and variety of infections, and then systemic diseases like sarcoidosis, progressive systemic sclerosis, Sjogren syndrome, and allergic atopic keratoconjunctivitis can be another cicatrizing conjunctivitis, and then local infections. Next slide. How do you make a diagnosis of OCP? Can you click Harika once so that there's a video which can play? Yes. So this is a OCT medium. Can click once more. There's upper left corner video starts. So this is how you take the biopsy of the cones in a patient suspected with OCP. So you take a biopsy, then this liquid nitrogen with the cartridge, you put that OCT medium and then embed this tissue which you are seeing in the upper left corner, immediately snap freeze it, and then it becomes a block, and then you do a immunofluorescence, the staining which you are seeing in the green color. And typically what you see is a apple green basement membrane staining which we look at fluorescence microscope. Next slide. Next slide. Then these patients need systemic immunosuppressives. I'll talk before that. There is a term called pseudopemphigoid. It is clinically indistinguishable from the OCP, and usually it is caused by drugs like pilocarpine, mostly anti-glaucoma medications. Some of the idoxuridine we don't use as antiviral now, and the only way to differentiate is when you stop these medications, the progression stops. Otherwise, histopathologically also you may find similar features. And glaucoma medications require toxic and they cause fibrosis. That's why they give the appearance of pseudopemphigoid. The treatment consists of, can you go back? The treatment consists, next slide. Yeah, the treatment consists of the systemic immunosuppressive therapy. So it is primarily a systemic disease, needs systemic immunosuppression. Topical steroids, lubricant, other things can help improve the patient's comfort. And then other treatments like scleral contact lenses, surgical management, depending on the situation. We will not go into the details of immunosuppressive treatment because that's a topic by itself. But I strongly recommend you to get familiarized with ocular inflammatory diseases and their management with systemic immunomodulation. Next slide. Can you, this is a video, can you click once more and increase the volume a little bit? Yeah, that's it.
They told me my eyes were melting away, both of them. And they fed me here to LV Prasad Eye Hospital in India. When I met Dr. V.S., my vision was zero because my eyes were not even opening at all. There was nothing like left on the eye. He said he wanted to do an immediate surgery for the complete reconstruction of both eyes. He said I had to give my eyes time to heal. After that, he was going to do a corrective surgery to improve my eyesight. So as the eyes were healing, sight was restored on the right eye. I went through a cataract surgery, and right now my eyesight on the right has improved from 0 to 40%.
So next slide. This is a patient from Zimbabwe who had a sequel of chronic Stevens-Johnson syndrome, and the severe form of the same is called toxic epidermolysis necrosis, or its another nickname is Lyell's syndrome. These are complex immunological syndrome with acute blisters affecting the skin and at least 2 mucous membranes. The conjunctival and oral mucosa are the most commonly affected. However, rarely you may have the genital, anal, pleural, or esophageal mucosal involvement as well. Next slide. The terminology erythema multiforme major and minor. Minor is usually caused by the viral afflictions or viral fevers. Stevens-Johnson's and its severe form toxic epidermolysis necrolysis is the mostly drug-induced. Next slide. There are specific criteria for the diagnosis, like for EM major and minor, you have a typical target skin lesions, axial distribution, benign self-limiting course may occur, but infrequently involves the eyes, more related to the infection, especially the herpes virus. Next slide. While the SJS TEN or the Lyell's syndrome, it's essentially a spectrum, and there is an overlap. You may not be able to diagnose clearly. While TEN or SJH, you have widespread blisters, purpuric maculae, trunk and head distribution. It's a very serious condition, and patients' mortality is very high, and it's almost 80 to 90% of the times eyes are involved, and it's more related to drugs. There has been a study called SCAR study in Archives of Dermatology 2002, which is a very good article for someone who wants to understand these conditions better and their terminology. Next slide. Here is a gentleman who had looking at the surface, looking at the eye, they don't look very bad in the acute phase. You have magazine. He was diagnosed acute SJS, and in the subacute phase, he was referred for further management. Next slide. Now, when you look at the palpable conjunctiva in these patients, there is a dense membrane, true membrane. It's a pseudomembrane, not a true membrane. It's a pseudomembrane. You can peel it off, and the inflammation is intense in the palpable conjunctiva. So I'm removing this under local anesthesia, and then I'm going to put the amniotic membrane covering the both palpebral conch, the bulbar, and the cornea, even though the cornea does not look very bad at this stage. So why are we doing? When I started doing the amniotic membrane for acute SJS in early 2003, 2004, it was not very popular. But now there's ample evidence in the peer-reviewed literature that it is absolutely essential, and it's a disease-modifying treatment. Next slide. And nowadays, I would use fibrin glue rather than the sutures. Next. If now, when you look at the membrane which we removed and is subjected to histopathology, you can see intense inflammation in inflammatory cells, mostly lymphocytes, and therefore these patients do need topical and systemic immunomodulatory treatment. Next slide. With this treatment, this gentleman did have a favorable outcome, and with the Prose lens and topical lubricants, he could have a near normal, not 100% normal, but near normal life. Next slide, please. See, in Steven Johnson, EM minor on Lyell syndrome, the ophthalmologist plays a significant role in terms of the management. And in last 15 years, we have seen and devised variety of ways of treating them better rather than saying that nothing can be done. So this lady had a similar, the kind of gentleman who had the presentation, mild acute phase, and which was treated with multiple amniotic membrane on the ocular surface. Next slide. Followed by lead margin MMG, which was done by Santosh when he was in LVP. And subsequently, he was given these Prose lenses. And after that, I have done cataract surgery in both of her eyes, and she had maintained 20/20 vision. She does have to use frequent eye drops, but with the Prose lens or the scleral lens, she is practically normal. Next slide. So what happens is that if in the acute phase, 2 or 3 interventions are important. Number one, you should consider giving IV methylprednisolone, do amniotic membrane as soon as possible. And then in the chronic phase, as you are seeing in these videos, you have a tremendous amount of ocular surface damage with the lid margin keratinization and tropion and dystachiasis, dryness. Next slide. To my mind, next slide, please. To my mind and my experience, I think is the lid margin, which is the problem. And as I showed you in the acute phase, it is the palpebral conjunctiva, which is a seat of intense inflammation, and that leads to the subsequent sequelae. For chronic SJS with moderate to severe dryness, we have developed an algorithm where if the cornea is relatively clear, think of using a lubricants and scleral contact lenses. If there's an associated lid margin disease, then think of doing mucous membrane graft from the labial mucosa. If there is a opaque cornea, can you click Harika once? If you have a opaque cornea, then you can consider one of the 4 types of keratoprosthesis, one of the 3, MOOKP, which is modified osteodontokeratoprosthesis, Boston type 2, or LVP K-Pro, which video you are seeing here, which is a technique that we developed by modifying the MOOKP. I'll show you this this technique maybe some other time, but you can just see we first do a mucous membrane grafting on the ocular surface, sutures to the recti muscles, and then do a keratoplasty, like regular keratoplasty with the K-Pro mounted on the cornea, remove the lens, remove the vitreous, iris, and then you suture the K-Pro with the cornea in place and cover it with the mucous membrane again, and then you open a small hole in the mucous membrane. Now we have published these results and compared it with MOKP and other techniques. 5-year survival rate is about 70%, and the complication rate is far less than MOKP. Surgical technique is much simpler. Next slide. So here is what I meant the keratin or keratinized ocular, the lid margin. What you are seeing here in the upper left corner, white, pearly white, this is a deposit, it's a keratin secreted by the distressed epithelium. And when we say keratinized lid margin, the lid margin becomes rough and skin-like. And we are saying subconjunctival or submucosal fibrosis, that is the scarring, which leads to the contracture symblepharon, ankyloblepharon, and the entropion. Next slide. All of these are sequelae of the lid margin problem and the tarsal conjunctiva, which we have seen. Can you click once more? Once more, yeah. So these are the manifestations which you can see the keratinized lid margin. And when you have this keratinized lid margin, then damages the ocular surface, and then the whole course goes downhill. So the treatment of condition in this stage is lid margin mucous membrane grafting. Next slide. And this is what happens. Can you click once more? So this is what happens if you do not do lid margin AMG at early enough. These are the patient which, like within 6 years, within 5 years, within 1 year, the ocular surface goes downhill. And these eyes could have been saved if we could think of doing the lid margin MMG early on. Next slide. And this is how you do a lid margin mucous membrane grafting, a very quick short video of removing the keratinized lid margin. And this surgery can be easily taught to any of the cornea specialist or a general ophthalmologist who are interested. And obviously the oculoplastic surgeons are the ones who do it regularly. And Dr. Honauer used to do a lot of my SJS patients MMG. So we used to co-manage these patients in LVP. Harvesting the mucous membrane from the lip is initially little challenging for the ophthalmologists because they are not used to harvesting or working in the mouth, but it's not technically very demanding. Once you remove, debulk it, remove the fat part, then divide in 2 pieces, and then you use a combination of fibrin glue and sutures. And this becomes a new lid margin after about a week or 2. The mucous membrane is taken well and well integrated. Next slide, please. The published result of this technique of lid margin mucous membrane grafting is very dramatic improvement, more than 90% symptomatic improvement. I have patients who are now 18, 20 years follow-up and their cornea is shining. They don't become 100% normal. They do have some discharge, light sensitivity, but those are manageable with Prosilence, are manageable with topical steroids and antibiotic off and on. But the ocular surface can be saved. You don't have to do a keratoprosthesis because keratoprosthesis itself has its own problems. So it is a significant intervention. Next slide, please. Next slide. So these are some of the patients' eyes before and after. Go back once. Yeah, click, and stop. It's okay. The essential point is that we showed that there is a dramatic improvement. So to summarize, in acute SJS, you should think of doing amniotic membrane as soon as possible, either taking the patient in the ophthalmic OR or going to do bedside. Give IV methylprednisolone, provided there is no infection. In the chronic phase, lubricant and lid margin. If you manage them, and as and when there is a cataract too, and the PROS lens. These are significant improvement in the management of Steven Johnson in last 15 years. Here is now it changed the gears. This is a young girl who I had managed in 2001. She had this problem of lid itching, discharge, and there was a peripheral corneal thinning and conjunctival hyperplasia. There was an AC reaction, and she has 5 consultations before coming to me. And she was diagnosed variously people, chronic conjunctivitis, weak AC, conjunctival tuberculosis. So what I did was I did a conjunctival biopsy from this area where you are seeing the upper limbus where there's a thinning. I used TABCL. Next slide. What it turned out to be a conjunctival tuberculosis with the peripheral ulcerative keratitis and a necrosis of the upper tarsal area where supratarsal steroid injection was given for the treatment of VKC. She received full 8-month or 9-month of treatment with ATT, and she healed completely. Next slide. This is a patient from Calcutta who had a peripheral ulcerative keratitis, which was diagnosed as Moran's ulcer. Even though we consider Moran's ulcer as ocular disease, but it is a systemic autoimmune disease. So one of my colleagues in LVP did a patch grafting and did not give any systemic immunomodulation. Next slide. This is what happened. After a few months, the patient came with an aggressive disease, graft is melted completely, and there's a hole in the cornea in the upper part. At this stage, we did try to salvage giving IV methylprednisolone, oral Visalone, Imuran, but I guess it was too late. We should have done in the beginning when we did a corneal patch graft. And this is an example of specific immune response. Specific means it was directed against the corneal antigens, S100 proteins in the stroma, which are expressed on the keratocyte in the donor patch graft. Next slide. So peripheral ulcerative keratitis is a crescent-shaped destructive inflammatory lesion, as you can see in these photographs, which is with a subepithelial infiltrate and central edge. It can be infectious or non-infectious, but most important is that about 50% or maybe more are associated with systemic diseases. Next slide. And the significance for ophthalmologists to pick up the PUK. For example, PUK and necrotizing scleritis is in a setting of a collagen vascular disease, or patient who already have a diagnosed disease, or the patient who have these conditions think strongly about systemic collagen vascular disease. And what it tissue-wise means, that the disease has switched from synovial microvasculitis to systemic vasculitis. And these patients need systemic immunosuppression. In a study which I published when I was doing fellowship with Dr. Foster, that it can be a presenting sign of Wegener's granulomatosis and polyarthritis nodosa. Therefore, we must learn to refer these patients, especially take help of rheumatologist. Next slide. The approach to PUK would be always look at the systems, meaning a systemic examination, rule out surface problem, rule out infection, and also autoimmune etiology. Next slide. The differential diagnosis can be inflammatory, degenerative, or associated with the contiguous tissues. Like in patients with scleritis, you may see PUK. In neoplastic and metabolic disorders. So it's not only a systemic disease, but in about 50% of the patient, it may be other conditions, or it can be a masquerade. Next slide. Another important local conditions you need to differentiate Terrien's marginal degeneration from Moran's. Terrien's is a degeneration, while Moran's is an autoimmune disease. And the treatment and the way you manage is very different. So it's a critical distinction. Next slide. Another important distinction is, are you dealing with an infectious disease or a non-infectious? Looking at the PUK. So on the left-hand side, important infectious causes are HSV, VZV, and bacterial causes can be for PUK. Systemic or non-infectious causes are rheumatoid arthritis, Wegener's granulomatosis, relapsing polychondritis, and polyarthritis nodosa, rosacea, Moran's, marginal keratitis. Next slide, please. And the PUK can be associated with a lid margin disease. Very simple, but very, very important cause to rule out. It can also be in, it's called CLPUK. Contact lens users may have a peripheral ulcerative keratitis or infiltrate. And these patients need to be seen by a cornea, can be treated by a general ophthalmologist and need not be referred to a cornea specialist. Next slide. The Moran's ulcer and PUK with scleritis in a patient with rheumatoid arthritis. Again, the treatment, the way you work up will be very, very different, because for suspected Moran's ulcer, there are Watson's criteria. There are 5 of them. If you fulfill them, you really don't need an extensive workup. For rheumatoid arthritis, if it's diagnosed, you really don't need further workup, but need a management plan. Next slide. So almost 30%, 53% of the patient have systemic diseases, and these are collagen vascular disease. Next. The most common causes of PUK is rheumatoid arthritis, the highest number, and then it can be lupus, Wegener's, relapsing polychondritis, ANCA-associated vasculitis. Again, a very important cause. And when I came back in 98, most people told me that Wegener's we don't see in our country. Now we have large series of Wegener's from SN, from LVP, from PJ Chandigarh, and people are becoming more aware. Next, please. Rheumatoid arthritis is the most common cause of non-infectious PUK and is bilateral in about 44%. In these patients, if you have PUK or necrotizing scleritis, the chance of death or visceral vasculitis is very, very high. And these patients need serious systemic immunosuppression. Otherwise, they may succumb to systemic vasculitis. Next slide. The treatment options for ophthalmologists would consist of conjunctival resection with TABCL, systemic immunomodulation, and depending if there is a perforation, patch graft, or PK. Next slide. And these patients need frequent follow-up. Another very early study in 80s by Foster and colleagues shown that if the patient receives systemic immunosuppression, their not only eyes, their life is also saved. Then patients who did not receive immunosuppressive, the survival rate was much poorer as compared to those who received. Next slide. So there are now some of the skin disorders like epidermolysis bullosa. It's not just the name, you read in a textbook. I have managed quite a bit number of patients of epidermolysis bullosa, very young kids whose epithelium never heals. It's slight trauma, it comes off, or spontaneously it comes off. There are 3 different types, which is maybe important for your exams, but I won't go into the detail. The essential problem here is in the hemidesmosomes, where there is a protein in the hemidesmosomes, which is not strong enough, or it's mutated. Therefore, the adhesion of the epithelium with stroma does not happen, and you have spontaneous blistering and epithelium coming off. And then you have the scarring pannus formation. Next slide. Xeroderma pigmentosa, another common condition. Even though if you look at the overall, it may be rare, but it's a autosomal recessive disorder, genetic disorder, have this surface related problem like this, what you see in the skin, and all PK does not work. I have treated a few patients with the keratoprosthesis, which has worked for 8 to 10 years. Next slide. In diabetes, you have variety of ocular problems, but I'm talking only about the cornea. The fundamental problem in diabetes, diabetic cornea is the thickening of the basement membrane. And when you have thickened basement membrane, what happens is the epithelium is very loose, just like in epidermolysis bullosa, but the mechanism is different. Therefore, also you get corneal hyposthesia, PEDs. When you do surgery, it may come off and healing becomes again a problem. Next slide. The other metabolic disorders, rare ones, mucopolysaccharidosis, hyper and hypolipoproteinemia, Fabry's disease. So these are not very often, but are important for your exam point of view. Next slide. And these things you can find in a standard textbook. Golden heart syndrome, Ehlers-Danlos syndrome, Marfan syndrome. I have treated, managed all of these syndromes of different diseases at different presentations. Next slide. Nutritional disorders of cornea. I think the most important, vitamin A deficiency. And even today, it is still a problem in some parts of India, especially in Uttar Pradesh, Bihar. Rest of the India, probably you don't see that many patients. Next slide. The varied presentation of vitamin A deficiency in the eye can be night blindness, conjunctival xerosis, these spots, dry spots on the temporal or medial conch in the interpalpebral area. You may have conjunctival xerosis. I have seen young kids with corneal melt or corneal scar. So remember, in patients with protein energy malnutrition, vitamin A deficiency can be an important cause of corneal melt. Next slide. Hematological disorders, not very often, but important to remember, especially anemia and sickle cell disease and secondaries from leukemia. Next slide. Thyroid ophthalmopathy is something quite often, and diagnosis generally is not very difficult, but these, again, it's an autoimmune disease and needs a very, very specialized treatment. The earlier you pick up, the better you can manage. Next slide. Ocular GvHD, graft versus host disease, it's a coming up disease. I used to see a lot of these patients in Boston, but here now, as the organ transplantation is increasing, earlier it used to be only one center in India, that is CMC Vellore, but now we are seeing many transplant centers in the country, and we see more of these patients. Next slide. The pathophysiology is that it's like a donor cells mount an immune response against the recipient. So it's the opposite or ulta of a rejection phenomena. And obviously the immune system, which is essentially used for rejection, is involved the similar type of cells, and the immune histocompatibility antigens are involved. Next, and it can be acute or chronic. Next slide, please. So there is in the acute GvHD, there are different stages described by Steve Jabs from Wilmer Eye Hospital. These stage 1, stage 2, depending on whether it's a hyperemia with chemosis or discharge, pseudomembranes, corneal sloughing. Next slide. Currently, I'm managing 2 or 3 patients of GvHD from different cities. More often, what we see is the chronic GvHD, and which is presents like cicatricial conjunctivitis, formation of symbliphron, lid anatomy malformation, meibomian gland atrophy, and most of these patients would need topical steroids, lubricants, pros lens, if required cataract surgery. I have done in couple of patients limbal allograft. What I did was 2 patients have treated in taking the limbus from the bone marrow donor. So the rejection does not happen. Next slide. Their management will be depending on what situation the patients are. Systemic steroid in the acute phase, and the chronic phase mostly topical and lubricants, cyclosporin. If there is pros lens might help, not might help, it helps very well. I have treated many patients, and then rarely keratoprosthesis. Next slide. The KCS is a important condition of the ocular surface, which is essentially a dry eye associated with collagen vascular disorders and Sjogren syndrome. And diagnosis is more clinical, but breakup time, OSTI, surface staining, osmolarity. We don't use osmolarity for the clinical diagnosis, mostly the TUBT and the surface staining. Next slide. In HIV and AIDS, you see all kinds of manifestations in the cornea and the conjunctiva. And next slide, the superadded infections, which are listed here. So I would not go in any of the details of these because these are big chapters for you people to read. Next slide. Then infectious diseases like chikungunya fever, where you can develop the corneal melt completely. I've seen 2-3 patients of chikungunya fever. Then we talked about conjunctival tuberculosis. Next slide. In dermatological disorders affecting, can you click once? This is very interesting. Yes, this is a Demodex, which you can pull out a eyelash and examine under the microscope just in a saline or KOH mount. And this can be a very important diagnosis, especially if it is missed. And nowadays, it's very easy to treat with a treaty oil. Next slide, please. These are other uncommon, not very often, is psoriasis, seborrheic dermatitis, atopic dermatitis. We see more often VKC than AKC, which is far more common. And these blepharitis and seborrheic dermatitis do happen, and their treatment is relatively straightforward with Johnson Baby shampoo cleaning, topical steroids, and lubricants. Next slide, please. So in summary, the systemic disease affecting the cornea are vast and varied. Some of them are very serious, which we discussed. Sometimes it can be a corneal manifestation could be the initial presentation of a serious systemic disease. So you need to be aware that. Also remember that the cornea and the eye are part of the human being. So whenever you think of, are you dealing with a local or a systemic disease? Learn to refer and co-manage serious systemic conditions, especially Wagner's rheumatoid arthritis, along with a rheumatologist or an immunologist. And be open to second opinion and refer when required. Thank you very much.
Thank you so much, sir, for such an elaborative class on this. We have a few questions, sir.
Yeah, sure.
Yes, sir. The first one is most of the time we don't know about the systemic disease. So what all minimum investigation should be done on those cases when we ask for the systemic investigations?
My advice would be to not order blanket systemic investigation. First, learn or remember that in second and third year of MBBS, we were taught physical examination. So try to understand which systems might be involved. Say, for example, if you are seeing a patient with a scleritis. In scleritis, I said that about 40 to 50% of the patient may have underlying collagen vascular disease. So you can think of a collagen vascular profile. And many of these patients need systemic treatment. So you may also want a baseline CBC, a chest, X-ray chest, and rule out tuberculosis. So essentially, you want to do minimal investigation, depend more on your clinical skills.
Okay, so is there like a list of this test which must be done in these patients, keeping in the scenario of the Indian scenario or like that?
Yeah, the list, that's what I said. I don't think that you should go with the idea that any patient, if I see scleritis or if I see PUK, so these are the tests I should do. The idea of my sharing with these complex things was that you need to customize your investigation based on your clinical finding. Say if you have a patient with scleritis or associated retinal vasculitis along with PUK, then you will strongly think that I'm dealing with a systemic vasculitis. You should think of Wagner's. So ANCA becomes important, CRP becomes important. the routine set of investigations, CBC, ESR, X-ray test, Montus test is baseline for all of these patients. You may not need rheumatoid factor level in every patient. You don't need ANCA in every patient.
Yes, sir. The second is, in rheumatoid arthritis with scleral thinning, how long should the patient be on systemic immunosuppressive treatment, and which drug should be used, and what should be the doses, sir?
In patients with rheumatoid arthritis, thinning or scleromalacia is not a active condition. It's a thinned out sclera due to repeated inflammation. So if there is no active disease, I would not treat that patient systemically. So if there is an scleritis or if there is a PUK, and I also find serum markers of active disease. Even if I don't find serum markers, local inflammation is warrants systemic treatment. So most important thing I start with is these patients systemic steroid along with methotrexate. My first drug of choice is methotrexate because it's cheap, it's least toxic, and it's quite effective. If I have necrotizing scleritis with PUK, I will treat that patient with IV cyclophosphamide and IV methylprednisolone initially as a pulse dose, and then switch them on oral cytoxan and or oral steroids.
Okay, sir. And how long should these be used, depending upon
these any systemic, as a rule of thumb, systemic immunomodulation, you should continue at least 9 to 12 months after the disease has become quiet or from the last recurrence. If it recurs, then the time counts again from that recurrence. Say you started today and you've given the treatment for 6 months, and till 6 months there's no recurrence, but then you have breakthrough recurrence in terms of the inflammation or a scleritis, then the first 6 months doesn't count.
Okay, sir.
You will start counting again from that recurrence had healed, and then you count 8 to 12 or 9 to 12 months.
Yes, sir. The next question is, in IgG4 related eye disorders, what is the main mechanism that IgG4 affects the eyes?
You mean IgE?
No, sir. IgG4.
What is IgG4?
Immunoglobulin G4 related disorders, IgG4 disease.
So that's in orbit, so that is not so prevalent in ocular surface. But yeah, there are scleritis now and anterior segment manifestations of IgG4 related disease. So it's mainly an orbital inflammation related concept.
Okay,
I'm not.
So that can also affect the anterior segment of the eye. Okay, sir. The next question is, whenever we are peeling those membranes, sometimes it comes out easily and sometimes it's stuck. So, should we, give a pressure, or we should make an attempt to remove that also, or whatever comes out easily, we should just remove that?
Whatever comes out easily, it's fine. But say a pseudomembrane in a patient with conjunctivitis, I would not remove the membrane. I would treat aggressively with topical steroids. In rare small percentage of adenoviral conjunctivitis, I have used systemic steroids as well, where you have extreme swelling and membranes. So membrane peeling I do only if I'm planning to do amniotic membrane.
Okay, sir, but if suppose there is an associated with a discharge and we want to rule out whether there is any infection associated with that, then should we take the swab and also remove a part of the membrane and send it further?
I think conjunctival swab will be good enough.
Okay. So membrane peeling should be done even a small amount, only if we are planning for the limbal stem cell.
Not limbal stem, amniotic membrane.
Sorry, amniotic membrane graft. Yeah. Okay, sir.
Sorry, तुम्हारे नींद आ रही है.
Sir. I was just looking through the other questions. I'm sorry, sir.
All right.
So yeah, so we are done with the chat box, Facebook, and the YouTube. Hot seaters, you have any questions?
Sir, I have one quick question. In patients with chronic graft versus host disease, we use topical tacrolimus and cyclosporin. Can you please tell us the doses, sir? That is 0.1% and 0.03%, but how many times the patient should put?
See, I tacrolimus eye ointment is something I would recommend strongly. The cyclosporin eye drops may not be very helpful. More than that, topical steroid predacetate or dexamethasone will be more helpful. The tacrolimus eye ointment use at night at bedtime.
So if you are giving topical steroids, how long should we continue? So is it that the patient will be on?
Not always, but if the disease is early, then what happens is you give a pulse dose, like in VKC, you give a pulse like 4 to 6 weeks. And if the symptoms improve, you can reduce the frequency. You can change it to a steroid sparing or a softer steroids like loteprednol or FML.
Okay, thank you, sir.
Ortsitis, you have any questions? I think we are done with the questions, sir. Over to you, Santosh, sir.
Thank you so much, Virender, for a fantastic talk. We'll have you back again for surgical management of ocular surface disorders later.
Yeah, thank you very much. Thank you, everyone, and good night.
Friday, we have Rajesh Sinha speaking, Professor Rajesh Sinha from RP Center speaking on corneal edema. Please be there. Thank you so much. Good night.
Thank you. Bye. Good night.
Bye.